Good evening, everyone. Today we are going to talk about the history, approaches, and types. I'm not going into the details of each block, but an overview. Welcome to my YouTube channel, Pain Free Partha, on my website, www.painfreepartha.com for free downloadable anesthesia slides. In 1884, Australian ophthalmologist, what he did is he instilled 2% cocaine into his own eyes and just pinpricked it so that he did not feel any sensation. That is how he invented and established cocaine. The following year, what happened was, after some time, 1885 or 90s, between that time, 1884, they say, using cocaine after that. William Halsted opened up the neck to spray cocaine into the brachial plexus and numbed the hands. Now I was looking at the thing. How did he establish anesthesia of cutting the skin? It was written that he infiltrated cocaine only. So that is how actually it was started brachial plexus block by open method by William Halsted in the 1890s. After that, so many people cut like that. But in 1902 only, 1911 only, Kulenkampff, he was the pioneer of brachial plexus block. And he described axillary and supraclavicular approaches. And Hirschel was the one who described the axillary approach better. And he said the risk of pneumothorax. See, in 1917, he said the axillary approach increased pneumothorax. There was a lot of controversies. How can you prick the brachial plexus with a paresthesia? How can you prick? How can you needle the plexus? How can you create a nerve injury? All these things were controversially done and after that settled towards paresthesia technique. And after the evolution in the mid 20th centuries, Winnie described the interscreen approach, the infraclavicular approach, the nerve stimulator in the 1960s and 70s. And now you can see after that 2000, you have come to ultrasound. What are the indications of brachial plexus block? Surgery of the humerus, surgery of the distal extremity, basically distal forearm hand procedures. Sometimes we do brachial plexus block for clavicle surgeries. Sometimes we do for breast surgeries because the medial and the lateral pectoral nerves are the branches of brachial plexus. Sometimes we do for breast surgeries. Sometimes we do for clavicle surgeries. Otherwise, it is all about shoulder and arm. We can have other indications like we can have put in a catheter here and then you can do this. And postoperative pain control, sympathetic musculation, vascular pains, all these things are other indications other than this. For example, now you have arm, clavicle, breast, vascular pain. We need sympathetic blocks. All these things are indications of brachial plexus blocks. The absolute contraindication is patient refusal. There is a local infection, local anesthetic allergy, severe coagulopathy. These are all the routine part. Okay. In any blocks, for example, we can say all these things will come. But specifically, we can see severe pulmonary disease, COPD, because one side, if you give interscalene, it may paralyze phrenic nerve. So, if there is a contralateral phrenic nerve injury, all these things are contraindications. A pre-existing neurological deficit, bilateral blocks, because diaphragmatic paralysis bilateral. Always give, when there is a bilateral injury, I always go for axillary block, at least on one side, definitely. Then I will go now for a costoclavicle with this side, axillary. So then chances of the so-called brachial plexus, phrenic nerve injury and diaphragmatic paralysis is almost nil. Now I have already told interscalene is for this shoulder, clavicle and arm surgeries, especially para. This is interscalene. You are in the interscalene plexus. Now you see supra and infraclavicular or elbow around the elbow surgeries, on forearm surgeries. Now axillary block is for wrist and distal to the wrist surgeries. Now the axillary will come here, the supra and infraclavicular will come here. So interscalene will come in the shoulder, clavicle and forearm. Now I'm not going to the details of interscalene block or details of each block, but I will just outline the block. Now this is the sternal head of sternocleidomastoid. This is the clavicular head of sternocleidomastoid. Sternocleidomastoid. Cleido means clavicle. Sternocleidomastoid. This is the clavicular head of the lateral border of the clavicular head. So this is most important. Lateral border of the clavicular. This side you can see anterior screen, middle screen and posterior screen. We are bothered about anterior and middle. Now you can see this is C1, C2, C3, C4, C5, C6. Below C6, the anterior scalene is thinner. That is what we need to know. The anterior scalene is thinner below C6. So the gap is wide below C6. Now, what you want to inject here is the lateral, here's the needle, lateral head of the clavicular and the sternomastoid from the cricoid cartilage line to perc. That is the position of the interscalene block. Lateral border of the clavicular head, this thyroid and cricoid cartilages intersection. The puncture is lateral and posterior to the sternocleidomastoid, just where the external jugular vein overlies. The brachial plexus, we know it is an interscalene groove. The needle is caudal, posterior and medial with a 45-degree angle. Now you can see this is the interscalene block. This is directed like this. The needle. Where is the? This is the cricoid and thyroid cartilage tip. This is the external jugular vein which is crossing. This is the lateral border of the clavicular head of the sternomastoid. Yes, we are inside here exactly to block the interscalene groove and the brachial plexus. There are a lot of approaches. Winnie said at the level of cricoid perpendicular in all planes. High risk of complications, vertebral artery, spinal cord. Mayer's modified, he said 30 degrees caudal and posterior towards the middle third of the clavicle only. From this thing, you are going to the third clavicle portion only. Here, you slightly go laterally towards the middle or the lateral third of the clavicle. Borges method. Pip come from the posterior. So these are all the various approaches to interscalene block. Interscalene block itself is an approach of brachial plexus block. There are a lot of things here. The needle direction changes from here or slightly here. There are various Borges and Pippas approaches. This is about the interscalene. Now we go to supraclavicular. Same here. Supine lateral border of the clavicular head of the sternocleidomastoid line along the clavicle. Puncture it here. Subclavian artery is in the supraclavicular fossa, very close here. This is where is the supraclavicular approach. Now we can see very clearly. This is the supraclavicular. This is the middle scalene, anterior scalene. Go down. Here it's a supraclavicular approach. Now we have got this is see the subclavian artery, but the subclavian vein is here. There is an in-between anterior scalene muscle. This is a routine type. Go just caudal, posterior, and slightly medial in this portion. 2 centimeters above the midpoint of this clavicle in the interscalene groove. Midpoint of the clavicle, 2 centimeters above in the interscalene groove. Go medial, inferior, and posterior. Okay, this is, you can also do a subclavian perivascular, palpate the subclavian artery and go push the subclavian artery medially and go laterally hit the brachial plexus. You can also go as a plumb bob approach. Plumb bob is this machine. The wire is made straight by this machine. So directly press the clavicle, just above the clavicle in the interscalene groove. Go directly here, hit the brachial plexus like this. There is always a risk of pneumothorax here in subclavian. There are a lot of approaches in infraclavicular. Supraclavicular is over. Infraclavicular means below the clavicle. Modified Raj. Vertical cast vertical. Prefers coraca. Clusters ultrasound guidance. Now it is basically, I will tell you in simple way, without the ultrasound, coracoid process, 2 centimeters medial, 2 centimeter inferior, go towards laterally, you have to use the peripheral nervous system, a nervous stimulator. So otherwise, peripheral nerve stimulator, without that, it is not possible to do infraclavicular approach. Now you can see, patient is placed supine, the skin entry mark is there, go lateral. This is what is classical infraclavicular approach. There are a lot of techniques, modified Raj technique, heel cast technique, 1 centimeter below the midclavicular point. Here, this is the needle process. Chromian brachial plexus is coming like this. When we point towards the midpoint of the axillary floor, when we point towards the anterior aspect, all these things, the approaches differ. That sets we will lock because it is about ultrasound guidance. There are 2 other approaches like costoclavicular, retroclavicular. They are only in ultrasound. If you come to axillary, what we do is we palpate the pulse and put needle above there, below there, and just pierce the sheath. Give through one side, the other side needle will come out. It's inside the sheath, then give 25 ml or something like that. You can also pierce the artery. Go beyond that. Give some 7 or 8 ml. Come above, and then give another 10-15 ml. That is what is called the transarterial approach. What are the complications? Hypertension, Horner syndrome, hoarseness, phrenic nerve, can go epidural, patient Gavin wheezing. Hypertension, what I have told is interscalene block usually. This is about interscalene block. This is about subclavian. This is about all things. So we can reach the epidural, we can even reach the spinal. Horner syndrome, hoarseness, because sympathetic is blocked. Phrenic is very close, lying in the anterior scalene. That I will describe the phrenic nerve when I go and describe separately the interscalene block. Pleural injury is the common side effect of subclavian. Now, this is the paresthesia technique, originally described, because there are few techniques: landmark aided paresthesia, peripheral nerve stimulation, ultrasound, and dual evidence. Current shock அடிக்கிற மாதிரி இருந்தா சொல்லுங்க. இப்ப இருக்கா? இப்ப இப்ப இருக்க கரண்ட் ஷாக் அடிக்குதா? கொடுங்க. 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 Now we have elicited paresthesia and given 8 ml only. Now I'll see in this slide what is happening. Now this is the first strip. This is the subclavian artery. This is the brachial plexus, which has already got a lot of liquid here. And here there is some. Okay. Almost entirely it has not gone in. So definitely a significant amount has gone into the brachial plexus. The other techniques are nerve stimulation, ultrasound, and dual guidance. You keep the ultrasound and also the peripheral nerve stimulator. That is what is called dual guidance. What are the complications? I already know: vascular puncture, 3 to 10%, nerve injuries, permanent nerve injuries, ultimate rare, pneumothorax, ultrasound, not last 0.03%. Phrenic nerve palsy will occur in 100%, around 40% in supraclavicular plexus. Infection is very rare. So I will by approach. If you think of interscalene, you think of phrenic nerve. If you think of supraclavicular, think of pneumothorax. Infraclavicular, you need peripheral nerve stimulator, and vascular puncture may be there. Axillary, incomplete block, because musculocutaneous will have escaped, and medial cutaneous nerve of arm, forearm, or branches of brachial plexus. We are targeting all the 4 nerves only. Now, history is about how Aztecs opened the neck to spray cocaine. Indications: not only upper arm, shoulder, clavicle, breast, and vascular pain. Types: interscalene. There are many types like PPAS, Borgiates, so many Winnies first. Then you go Supraclavicular, you can have subclavian perivascular, routine technique, and plumb bob. Then go to infraclavicular, traditional infraclavicular. You have to use the peripheral nerve stimulation. With ultrasound only, costoclavicular and retroclavicular. Then you go to axillary, either perivascular or transarterial.